Good afternoon, everyone. Thank you for joining us today. My name's Alex McFedrin, working with UNICEF Polio team out of WHO HQ in Geneva. Today we're going to discuss polio preparedness for VDPV outbreak response. And we have a few different sections to go through, including some time for questions and answers at the end. I ask that everyone stays muted for the webinar to avoid any complications in communicating, and otherwise we will discuss at the end with an open Q&A. So today we have three parts. The first, UNICEF Preparedness Framework for VDPV Outbreaks, presented by Sahar Higazi, Communication for Development Specialist with UNICEF. Then we'll have MOPV2 Vaccine Management Outbreak Preparedness, presented by Ahmet Afsar, Immunization Specialist for UNICEF. And finally, the review of gaps and practical preparedness steps for C4D, presented by Irma Manenkoor, from a Senior Management and Development Consultant. Our objectives today are first to do a brief review of the SOPs for C4D and vaccine management in polio outbreak response. And then, with that understanding, looking at and utilizing the UNICEF Polio Preparedness Matrix. We'll then consider communications and vaccine management readiness in your country office or regional office, and looking at the four key dimensions of prepositioning. So really focusing on preparedness, and finally, gaps and practical steps. I'm going to turn it over to Sahar, who's going to go through the UNICEF Preparedness Framework for VDPV outbreaks.
Thank you very much, Alex, and good afternoon, colleagues, or good morning for those who are still starting the day. First, let me start by having a very quick look at the summary of the SOP for polio outbreak response and taking a little bit zoom on the C4D and the vaccine management aspects of the SOP. And we're only zooming on those two because, as you all know, those are a UNICEF accountability area and the two areas where we lead on among the partners once we have a polio outbreak situation. As you all know, probably the C4D or the vaccine management part now, especially that after the switch, starts at point 0. So once there is a notification of any VDPV2 especially, this is the very first thing that the country team would have to think about in terms of what kind of a response plan and to what extent it would trigger a response that includes vaccination using MOPV2, which is an area that Ahmed would cover more through the webinar. From a C4D perspective, and as we go on to the 24 hours, this is the time as everyone who must be familiar with the SOPs start looking at social assessments, gap indicators, community assessment of the area. Then as we move on into the outbreak response phases from 72 to 14 days, this is where you start triggering your plan, pulling together the different elements, thinking about what should be out there, and maximum by 14 days, according to the SOP, this is where the first response has to be off the ground. So in other words, within 2 weeks from the date where you have confirmation of the outbreak, identification of the response and approval of the vaccine to be used, this is where, from a C4D perspective, you need to be ready and able to go directly into the implementation of your plan. So what does this really mean when it comes to the preparedness? So what should we be better prepared with in terms of the actual work? UNICEF looked at the preparedness framework for outbreak response, and we did look, if we go to the next slide, please, Alex, and we did look at what would be the main area and the main criteria and which countries should be considered for preparedness work. Initially, we looked at all the countries that have recently closed outbreaks, especially where improvement levels for vaccination and surveillance is still not optimum. As you all know, there are still many countries who are considered vulnerable, or there are some vulnerable population or risk areas, or some kind of one element or another that put them among the high-risk countries as identified by the RAT group or the risk assessment team. They look at all the countries in the world They look at multiple factors, epidemiological, population movement, surveillance situation, routine immunization coverage. Many factors are modeled, and based on which all the countries are being classified either as a very high-risk countries, high, medium, or low-risk groups. So among those who are considered as high-risk countries, and or those who have just closed an outbreak recently and still have some work to be done, or countries who are not exactly high risk, but they know that they have some pockets or some problem areas, geographical or among certain population, those are the ones we would think are the target for our discussion today, and they should take what we will be presenting today as something for consideration for the next few weeks. And the reason why we're raising this is that because we have seen from experience that those countries who were able to cover many of the points that we will discuss now were in a much better position to respond when the time has came, when and if and where they needed to respond. And without giving specific examples, I am sure each and every one of you, once we move to the next slide, you would see how helpful it would become if you have all of those ready under your thumb, as we say. So with this said, UNICEF developed globally what we call the Polio Preparedness Framework that does explain actually step, just one slide before, Alex, please. Yeah. That just put in context some basic areas that needs to be covered in terms of having the information available. So the first one, for example, would be to what extent you have data in place on the immunization coverage in the country. Is the data covered by national or subnational? Is the data specifically capturing the high-risk groups or population? Also, if there is, these are among the questions that you need to think and consider, for example, if there are national capacities in the countries, are there national capacities in the country or not? First, is there a national polio preparedness plan, and to what extent is it updated or not? Is the political support, government capacity to implement a quality SIA should and once there is a need for that? Are there vaccinators on the ground? Is the API program functioning, and to what extent is capable of planning a campaign immediately? Are there updated micro plans? In many situations, all of what I've just mentioned could be there, but there is no updated micro plans, and it needs to be completely redone if required. And to what extent, from an internal UNICEF point of view, we do have the internal capacity and the knowledge of who's who on the ground? Should we need to do some community work? Should we need to do any kind of pre-campaign awareness raising? And do we really have the capacity in place to do that? I will skip the points on the vaccine management and the C4D because those will be covered by Ahmed and Irma in a minute. But also among the issues that in the polio preparedness framework that we do consider and look at is the partnerships and advocacy. Is the government having any sort of forums to discuss, should there be an outbreak, to discuss the outbreak situation, like an ICC forum in some countries, an EOC format? Is there any kind of mandate for one group to be able to call on that? All of what I'm just mentioning should be naturally in the national preparedness plan of any given country. So if there is no one that exists, you should check out where is it exactly, but there should be, of course, one. If it's not updated, this is exactly the discussion that you need to have with WHO colleagues to make sure that one is updated very soon if you fit any of the criteria I have described on the slide before that. The same thing applies if you're in a country where there are some access and security issues. Is there an accessibility plan? Is the plan updated? Do we have clear maps of those areas if we need to intervene there? And finally, among the issues that we also need to consider internally from UNICEF, if we need in an outbreak context to respond quickly, are there any fast-track mechanisms in the office? How far can you really take the funds and ensure that in no time it gets to the lowest level required? So once you collect some information, you need to consider, okay, what do I do with this information? So in the concept note that is available with the UNICEF preparedness framework, We give you some examples or some suggestions for possible core interventions that you may need to look at to strengthen your capacity should you need to respond to an outbreak. Among those core interventions, that you update your risk assessment for the high-risk districts or population, that you look into the data, that you work with WHO on the surveillance strengthening plan, for example, on your vaccine management or C4D, as well as many others that are very much listed into the concept note, and some of those examples are here put for you. So to start off, after the presentation, what we will do is that there will be a link available to share with you the concept note, as well as an Excel template that comes naturally with it for you to go over different aspects that I have just presented. And you basically need to look at the different indicators as is showing now on the screen. And you will find that there is a drop menu under each of those indicators so that you can complete and fill those forms easier. It becomes very easy if you have the knowledge for that, and you normally in any country office situation, because it's a yes or no or maybe or some of that, then the completion of that Excel sheet does not really take much time. What happens is that in any given region, the regional office will be working directly with the country offices to complete that sheet. You bring it back to the regional office, and from a regional perspective, the regional office would compile, and as you can see, you will have on the very far left the different indicators by different areas, and then the ABC, for example, represent the different countries, and then it would tell us from a regional and HQ perspective in that particular location what are the specific gap areas that collectively we need to work on. If those needs to be prioritized in terms of your work plan, if those would require some additional funding, and or should this country is specifically a high-risk country and there would potentially or possibly be some outbreaks, what are the immediate things that we would have to note? And that compilation that is offered by or that is done by the regional office based on the deliverables or the inputs that is given by every country office, this is updated on 6 months basis, and it may not offer new information, even that's fine if there is nothing more to be added, but if required, especially on capacity building or any specific problematic areas, this is exactly where it brings an opportunity to include as part of your either funding request and or your work planning in general. So I will stop here at that part and pass it on to Ahmed to take the next module specifically on the vaccine management. So some of that would probably start to make sense once we move forward into the webinar, as well as when Irma present also the C4D part. So over to you, Ahmed. Thank you.
Thank you very much, Sahar. So I think, yes, Alex is giving me the right to change my slides. Thank you very much, Alex. Good afternoon, everybody. So as Sahar said, the preparedness is very important, especially for the MOPV2 vaccine management activities during an outbreak. So I just want to go through a couple of slides, and hopefully we will have a chance to discuss a little bit after that. So I'm afraid, Alex, I cannot change the slides. Can you move to next one, please? Thank you. So the vaccine that we are using in an MOPV2 campaign, the MOPV2 vaccine is a very special vaccine. Why it is very special? Why unique? Because it's not registered in any country that any of us, any countries that currently using or expected to use. So it's not available to purchase. So you cannot just go to a manufacturer and buy this vaccine. So it's not possible. And it's available only from a stockpile controlled by WHO. WHO actually owns the stockpile. And UNICEF handles the logistics part, all the shipments, inter-country shipments, and country deals with the stock management after they receive the vaccine. But as I said, it's only available from the stockpile. And since it is coming from a stockpile, you really need to use a special request mechanism, a special form that we are going to discuss a little bit. A special form is needed, so you have to make some special planning activities before making your request. And it is very important to handle it with carefully, with very precise storage and transaction records. And it should be done all through the supply chain. So containment is needed between the rounds and at the end of the last round. So you have to recollect the vaccine after each round and store them in a secure place. And then if there is another round, if there is a second round or third round, you have to bring those secured vaccines back to the field. So actually it requires a reverse logistics activity, which is very unique. So normally in most of the countries that conducting SIAs, supplementary immunization activities, they don't have this kind of mechanism, and they don't have this kind of reverse logistics activities for routine immunization also. So it is very important to make the plans according to these requirements. And at the end of the campaign, you have to dispose of, after the last campaign, you have to dispose of all the MOPV stocks like we did during the switch. So as we destroyed all the TOPV stocks, we have to destroy all MOPV2 stocks after the last round. But it is not something that we can just decide on how to and when to destroy the vaccines. It's usually the outbreak response assessment team who is visiting the country and closing the outbreak will let us know if we are ready to dispose of all the MOPV2 stocks in the country. Next, please. So actually MOPV2 is something that we already know. I mean, this is the type 2 component of TOPV. So we have been using this for years. It's the same vaccine actually. And I mean, now it is packed as a single antigen vials. So and the vial size is a little bit different, or the vials are a little bit different from the TOPV, but almost it's the same with current BOPV vaccines available from the manufacturers. So it is pre-qualified, WHO pre-qualified vaccine. So and licensed in Belgium. So National Regulatory Authority of Belgium control this vaccine and check if it is up to the quality point that we require and WHO require to use this vaccine in the countries. So it is again administered orally. So one dose is 2 drops. It's very similar to what we have in BOPV. It's the current batch comes in 20 dose vials. So, and we have VDM2 on it. So it means that it is sensitive to heat as BOPV. And so we try to keep it in minus temperatures as long as possible. But it is possible to keep it between 2 to 8 degrees Celsius and refreeze it like we can do with the BOPV. So the volume requirement is about 0.5 cubic centimeter per dose. So this is important when you are having your preparedness plans for the vaccine storage capacities. So in one box we have about 100 vials, and in 100 vials is about 2 liters, 1 liter for 2,000 doses. So 1 box is 1 liter, so you can just estimate the capacity need from these figures. Next, please. Okay, so how we can understand if we are ready for an MOPV2 campaign? So we have some indicators. You can create more actually, but these are the key indicators that important for us to organize an MOPV2 campaign. So we usually do house-to-house campaign. We usually use MOPV2 for house-to-house vaccination. So do we have a cold chain logistics system for house-to-house campaigns? So it is important to make that decision. So you really need to have enough quality and quantity equipment, and you really have to have the vaccine carriers and ice packs to conduct a house-to-house campaign. So it really takes a lot of preparedness. So you really have to make your plans, check your cold chain equipment inventory, and some other things. And the stock management, we said that very stringent stock management system is needed for MOPV2, because actually you have to follow all the vaccine vials. There should be a very good vaccine tracking system in the country. So you have to distribute all the vials that you want to distribute, and you have to know how many vials were distributed, and you have to recollect them, empty or unopened vials, and you have to track both empty vials and unopened vials. So it is quite a job actually, and if your system is not ready for that, if your preparedness plans are not ready for that, it's very hard to organize this activity, this reverse logistics activity in last minute. So you really have to prepare yourself. And you really have to prepare your staff. So the staff readiness is a very important factor. So you have to organize MOPV2 trainings. If you are not going to organize right now, you have to prepare your training material, and you have to update them when the time comes when you have to use those training materials. But you really need that the trained staff and some very well trained supervisors. It is much stricter than the VOPV campaign. You really need supervisors also very well trained, so they can follow up the vials, so they can return all the vials back to the central stores. And that recollection and disposal plan should be in line with the global guidelines. Current guidelines are saying that just follow the TOPV, BOPV switch guidelines, so which is actually you have to collect the vaccines, and then you have to destroy by using boiling or incinerating or I mean, several methods are recommended, but I think it's the best way is high temperature incineration, and currently most countries are using this when MOPV2 is being used. So can we move to the next slide, Alex? Thank you. So the preparation is, as I said at the beginning, at the beginning of the campaign, you really need to get the permission to use this vaccine. And it comes from WHO Director General, and it should be discussed with the advisory group on MOPV2 provision. So that process is required, but while the process is going on, you have to prepare your special vaccine request form for the MOPV2. It is available on polio eradication website, and you can use this link, but it is available on polio eradication website, and it can be updated. Just don't go to website and download this, but know where the document is. So when it comes, you have to download the latest version, and you have to fill in that form for MOPV2 request. And proper demand forecasting is very, very important. We have seen some very low quality forecasting. So some requests are too short to fill in the needs. It is actually the typical vaccine management for the BOPV campaigns. If you are in short, you can just borrow some BOPV from the routine immunization vaccines. But for MOPV2, we cannot do this because we don't have MOPV2 in the routine immunization. So you have to estimate your needs properly, and there shouldn't be any shortage. But you should also be very careful about estimating your needs. You shouldn't overstock, because the vaccine that overstock has to be kept very carefully in a proper temperature range, and they have to be moved within the country in proper temperature range within reverse logistics reverse cold chain system. So it is very hard to handle too much MOPV2 vaccine. And it's also, coming from a stockpile, and stockpile is limited. So at one point, we will not have enough MOPV2 to cover all country needs. So it's very important to make this forecast properly. And good forecast is depending on good target population estimation. So as part of the preparedness, you have to check your microplans, and you really have to check your target populations, and you have to update them and keep them up to date. It is also important to have this cold chain equipment inventory, and so you have to keep the inventory up to date. And if there are some risks, some missing cold chain equipment or non-functional cold chain equipment in certain parts of the country, especially in the parts that are under risk, you have to update the cold chain equipment there. Next one, please, Alex. Yeah, so reverse cold chain. I keep saying reverse cold chain and reverse logistics. I think this is important because, as I said before, this is not something that we used to, the immunization systems are used to. We were using reverse cold chain only for the samples. So stool samples were, we have been keeping stool samples in the reverse cold chain, but not the vaccines. And it is very important to design your system or review your system design once more to have the reverse cold chain activity. And your reverse cold chain activities has to be recorded also. So you really need to have some record keeping system when the vaccine is coming from the field to a central store. So the standards are the same, should be the same. So you have to be very careful about temperature management when you are returning the vaccines back to the central store. OPV is like other BOPV. MOPV is like other BOPV. Can be repeatedly frozen and thawed. So it is very typical that at one point you can keep the vaccine at minus 20 degrees Celsius, and then you can keep it between 2 to 8 degrees Celsius, so it will be thawed. And then it will be frozen again when you are keeping the vaccine on return in a high-level storage if you have the freezer's capacity, enough freezer capacity. And this doesn't damage the vaccine. So actually it is good to keep the vaccine as much as possible in the minus temperatures, So you can keep the vaccine VVM without VVM changes. So it is very important. So you can extend the vaccine's lifetime. And when you are returning the vaccines, unopened vials back to a higher level, you have to check the VVM status, and you have to check if the labels are still intact, they are readable, and if there's any damage in the vials, so there might be some cracks or something. So if you see there are some changes in the vial quality, you shouldn't return them in the cold chain, so they shouldn't be used, so they should be separated, and you have to return them back to the higher levels in ambient temperatures, like all open vials. So next one, please, Alex. I just want to show you one picture. So this one, you can see this guy is the UNICEF logistician. So when we were finalizing the one day or first day of the campaign, we were just counting the vials and packing them and sealing them, signing them. You know, it is very important to return even the empty vials. And it's very important to return all of them. So you really have to count one by one and seal and send back to a higher level for incineration. So this reverse logistics plan requires some additional items to plan from the beginning. So, for example, you have to use Ziploc bags. That small plastic bags are very important, very critical. So actually you can pack the empty vials in tents. So each small vial, each small plastic bag will have 10 vials. It will be much easier to count in if it is 10. And you can also check the quality of the vials. So it is very key supply for this kind of campaign, which we normally don't use. And disposable boxes for returning the vaccine vials, and some sacks, depending on the country. They have to be very well planned. Next one, please. Yeah. So the most important thing is actually to prepare yourself, prepare your staff. So we have some tools to use for capacity building. So we have a guidance note that you can see here on the right hand side. It is available in French and in English. So we are finalizing the Arabic version. So that's actually a very good key document. It's a aggregated guideline document. So there are several guidelines, WHO guidelines. Just selected parts of WHO guidelines are collected in this guidance note. So it is actually a very key document. It is very important to go through that document and for preparing your preparedness plans. And the e-learning course is also possible to use those courses before preparing your preparedness plans, especially. So you can use English or French version, and it is open to everyone. You can just register yourself to UNICEF e-learning platform, Agora, and you can just search for CCL or search for Polio, and you will see this course both in English and French. And doing your homework is important. So my first, I think the last recommendation today is just go through these documents first. Go through the Polio Education website and see all the capacity building tools there, and then after digesting all of them, start preparing your plans or updating your plans. Thank you very much.
Thank you, Ahmed, very much for that very informative and look at preparedness for CCL and VM. We're going to take a very quick 5-minute time period here to look at some questions. If you have questions, please type them into the bottom left corner where there's the little speech bubble on your screen, and Ahmed will answer them now before we move on to C4D. So if you have questions, please go ahead and write them, and then I'll read them out loud for everybody, and Ahmed will answer them. We have one already from Mehmet. It is, what is the acceptable dropout rate for MOPV2? Oh, someone else just bumped him up. MOPV2 flacons. I mean, for trivalent OPV, we could vaccinate only 14 to 16 children. Is it also valid for MOPV2? Over to you, Ahmed.
Okay, thank you very much. So actually, this is not dropout rate, the wastage rate, I guess, and it is something like between 5 to 15% wastage rate is acceptable. But this is for the open vial wastage. Unopened vial wastage, actually, it should be zero. I mean, there shouldn't be any logistics problem. There shouldn't be any unopened vial wastage. So it should be as low as possible. Zero is the best. But for open vial wastage, yeah, we accept between 5 to 15. And if there are some very hard to reach areas that you have to vaccinate children, it might be even higher, but it is acceptable. So we don't call them wastage, so because they are still used for the kids.
The next question is from Hussein. How many days does it take to require to get vaccine in country?
There is actually supply chain, supply division is working very hard on that. They usually, I mean, in most cases, they manage to bring the vaccine to country in 7 days. But this is, you know, you really have to be very, very lucky. It really depends on the flights. So in certain countries, you cannot find the flight because you have to carry the vaccine in plane. So air cargo is the only way to carry the vaccine. So you really have to be, I mean, you depend on the air companies or airlines or the how can I say, the capacity in the country, because some countries do not have that capacity. They don't have an airport or reliable airport. So it takes a little bit longer for them. But mostly, our target is trying to finish the shipment within 7 days.
Thank you, Ahmed. 2 more questions for you. From Kamal, usually the collection of remaining vials at the end of every vaccination session and at the end of each SIA round is not enough stressed in the training manuals addressing vaccinators and supervisors. Is there any additional instructions in SIAs using MOPV2 to ensure that getting back all remaining MOPV2 vials will be done properly?
Yeah, we have a guideline, MOPV2 technical implementation guideline in polio education website. So it is a very important guideline. So if you can go through that MOPV2 implementation guideline, you can find all the details. So it's a very good question, though.
And last question, a bit of a statement from Hussein is, I think we could also include expiry date in addition to the VVM and label on the vial.
Can I get the question again?
It's more of a statement, just stating that I think we can also include the expiry date in addition to VVM yeah, and the label on the vial.
Yeah, it's true. Actually, but the vaccine that shipped to the countries usually have something like a minimum 1 year expiration period. So more or less, we close we destroy all the vaccines within that period. So expiration date is that's important thing, but VVM changes happens very quickly. So that's why I'm just underlining VVM.
Great. Thank you so much, Amit. We're going to let Amit get back to the tools harmonization for CCL and VM workshop that he's actually participating in Chad right now. So thank you very much, Amit, for joining us. And if anyone has further questions on VM or CCL, you can write them at the end of the presentation and I can forward them on to him. So now we're going to turn it over to Irma, who's going to go through the review of gaps and practical preparedness steps for C4D.
Thanks so much. I noticed that there are a number of colleagues online who also have been involved in working in polio outbreaks or polio eradication, so I'll be looking for them also to discuss later some of the practical situations they've encountered as well. But I think one of the key things to keep in mind, building on what we heard from Sahar and the overall UNICEF preparedness framework, is thinking about what are 6 key indicators for C4D. And they tend to focus around 2 major areas. One is data, and the other one is staffing. So if you look at this particular slide, what you will note is one of the things that we think is really critical is having information or data related to immunization behaviors in general. And that's really an understanding of how recent is that information. Sometimes we find in countries they have data, but it's like 10 years old or 15 years old, so it's not really useful for what they're trying to do in the immediate outbreak potential situation that they may face. To what extent does the office have information and data on audience segmentation and media consumption? And finally, what is the available communication data on immunization? So sometimes offices will have the behavior, but they really haven't looked at it from the point of view of communication. So trying to get a handle of what's the match that may exist in terms of what we know in terms of the facts and actual data in a country. On the staffing side, 3 things come to mind that are really critical. First of all, does the office have C4D or other experienced communication staff within the country structure? And if they do those individuals have experience in immunization and polio? Because we know when we're working in this particular area that given the epidemiology, the technical understanding of what's happening in health becomes a very important skill to have and knowledge base to have in trying to do the behavior and social change programming. And the 6th point, which also relates to staffing, is what is the surge capacity of an office? Do they have enough staff within that office or access to consultants or networks to deploy if there is an outbreak? So those are some of the key indicators one would want to have as a guide in terms of thinking through preparedness. What then concretely do I need to begin to think about putting in place or having put done to help me get ready for an outbreak should it happen in the country that I'm serving? So there are 4 areas we're going to talk about in terms of prepositioning C4D. One is strategy, content, and messages. Spend some time talking about human resources, going back to look at this issue of research and data and what do we really mean by that when we talk about an outbreak or getting ready for an outbreak. What can we do ahead of time? And ultimately, what can we say about materials and tools? I think when we look at the issue of strategy, a country office has possibly 3 different types of strategies that can be considered as they're planning or thinking about a potential response should it happen to them. And what you have in front of you are the 3 different types with countries who have actually used those particular models. The first one, the community outreach model, is one that builds upon structures that may be strong already in a country, so it assumes that the country has the capacity itself to respond. And UNICEF's role in that case is really supporting the government who uses its own workers to do the work involved in polio, responding to an outbreak. The key strength is, of course, is it builds on the national system and the national workforce. Some of the challenges with that, of course, will be around supervision, quality control, the accountability mechanisms. Even though we may know the systems in place, is it working to the level it needs to work would be the question one would want to follow. And you see that there have been 4 countries up to this point who've been using that particular model. The second one is parallel outreach, and probably the most famously known country using that was India initially, and of course now Nigeria and Pakistan. And that means literally that UNICEF has put in place a parallel system to the government system to actually bring social mobilizers on board that it is financing and supporting, in addition to whatever the government may have on its side in terms of trying to respond. The assumption in this particular model, or the conditions in this particular model, is generally that the government system is weak, is not sufficient in the high-risk areas to respond, and therefore an extra push is needed to really make it happen. So on the positive side, what it does do is push for and allow for maximizing performance, because there's a control over the staffing, there's dedicated staff for the supervision. One is not depending upon a government worker who may have 2 or more other things that they have on their portfolio to do. But the weakness is, of course, it's cost intensive, it's management intensive, and because it is a parallel system, if the funding goes, the likelihood is the system may not be picked up and may disappear. The third model is the rapid response, and this is where UNICEF works directly with local NGOs, networks, and staffing to actually mobilize communities to respond during an outbreak. And we've seen this particular approach used in the 5 countries that you see on your screen. Its strength is that it builds on existing skills, and it builds on strong community links, because it is looking at and trying to reach and work with community networks that are already in place. The real danger perhaps here, or the challenge, is that the quality of the program is dependent upon the local implementing partner. And so you may have issues that reflect their own relative strengths or weaknesses. The idea is not to say that there's one model better than another, but is to say those 3 options are those to be considered given the state of the government and the government's own ability to respond should an outbreak. But one would want to have a sense ahead of an outbreak what potential model might be the one that would be used in the country in which you're serving. So that's thinking about it from looking at strategy. In terms of content, one of the things we know is that there are about seven different things to keep in mind, at least when we're talking about polio. And that when you're thinking about an enduring outbreak, which Sahar talked about earlier, one of the issues you have to deal with is repeated campaigns, how to explain that to people, perceptions that the vaccine is unsafe, or that it's ineffective, or there's mistrust about the workers or what the campaign is trying to do. We saw in Nigeria, for example, where rumors were spreading around what this campaign was trying to do. So you may have to address those kind of issues. The issue of refusals, and we talk about it as you see here, as children are not available. Sometimes it's a passive refusal. They didn't actually say no when you went to the door, but the child's not there, the child's sleeping, there's other reasons people are giving around why they're not allowing that child to be vaccinated. Issues around whether or not people believe that polio is curable can influence their interest, their desire, their willingness to vaccinate their children. And of course now we have issues of vaccine derived polio virus that causes issues. So these are particular content areas that, although you may have a great strategy in place, you've got to think about from a communication point of view, how are you going to tackle these kind of issues? These are the most common that we're seeing. Following that, the other aspect to keep in mind when we're thinking about strategy and content and looking at messaging is really trying to get a handle on the advocacy component of the work in our partnerships. So to what extent is there a government body or community committee at the national and subnational level for coordination of social mobilization? Oftentimes we see a coordination body, but when it comes to the social mobilization, it kind of falls to UNICEF to try to do it. And if you see it, if we're not careful, it tends to only be at national level. So we don't see things happening at district, at ward level to kind of coordinate what not only UNICEF may be supporting, but what other partners are doing as well. The other area to think about more closely is looking at community-based volunteers and NGOs. To what extent do they have experienced local staff that can help with social and community mobilization? To what extent can they share their cultural understanding of what's happening to assist in active case finding? A key area, I think, when we're talking about the whole polio preparedness from a C4D point of view is to what extent do we know about any opposition groups or anti-vaccination movements that may be in the with considerable influence in the country in which we're working? Because that means that we have to then think from a strategic point of view, how are we going to engage or how are we going to interact with those particular groups to try to get the movement and the motivation for people to have their children vaccinated. And finally, what established partnerships with NGOs and other organizations exist in the hard-to-reach areas in terms of community interventions. So those are quickly some of the key ideas around thinking about strategy, content, and messages. The next area would be looking into the whole aspect of human resources. And I've already talked about indicators in terms of staffing, but this really takes us to a much larger point of view of thinking about this, not just UNICEF staff. And so what we have available for human resources when you're thinking about preparedness are three particular things. One, there's the Global Polio Eradication Initiative Global Polio Roster, and some of you online are a part of this particular roster, which means you're available to be identified and in a surge capacity when a country might need it should an outbreak happen. What's been great to see happening, besides the global roster, all the regions have put in place regional C4D rosters and networks. So they've identified consultants within the region, organizations or institutions within the region that can help their country offices respond should they have to deal with an outbreak. In addition to the individuals, you do have an operational resource, which is the long-term agreements that headquarters has established with a number of organizations, whether they be research, whether they be in training, that can help you respond. And the next slide shows you where those resources are. And you see that there's a whole host of them from Harvard University, Johns Hopkins, Anthropologica, PCI Media, Rain Barrel, M&D, throughout the world that are available should a country need assistance of and beyond what they have access to already. They can tap into this LTA mechanism. There are over 30 institutions, and as you probably know at the moment, UNICEF is in the middle of tendering a new long-term agreement for C4D that should be coming out in January 2018 that will run from 2018 to 2020. In addition to these particular institutional relationships that have been established through the global network at C4D, there are over 80 Centers for Disease Control supported stop volunteers that are available to country offices. And you also see that there are partnerships with Islamic institutions and leaders through the Islamic Advisory Group. So there's a host of human resource support that's available of and beyond the actual staffing that a country office has. It's more a question now of knowing how to tap into those resources, whether it be through the global roster and working with the polio unit in Geneva to get that information, whether it be with your regional C4D officer in polio to help you look at what's at the regional network, or the long-term agreements where information is already available to you on the UNICEF intranet. The next area really looks at data, and what we try to think about in positioning for a polio response, should it be needed, in terms of C4D, is really trying to understand, to document and be clear what is the context or the profile of the outbreak risk areas. And this implies that you will have information already in your office, so you're not trying to catch it as the outbreak is happening, but you have information already in your office that you're familiar with around the demography, the geography, the security situation, who are the big influential non-governmental organizations, what type of local media you have, what are literacy rates, who really are the political and social influencers in the country. You have information on the media use and viewership and listenership. You have information around transportation. So what we're saying in terms of data is this is the kind of information you want to have upfront available. You want to know something about localized communities access. You want to know about borders or camp gathering places. You want to have a sense of the mobile communities. So we're suggesting that within the office, this is the kind of information. It doesn't mean that the C4D officer is the one collecting it, but that the C4D officer is reviewing this information. Go ahead. What do we really want to know in terms of access and high risk assessment? And you see in front of you kind of the key areas that we really try to get a handle on. What is the availability of the data in the risk assessment? To what extent is this data available and analyzed subnationally to identify high-risk areas? What data exists on refugees, migration, mobile populations? And what type of data do you have? Are you working from EPI reports or coverage data or NID data? Is it independent monitoring? Maybe you have information on neighboring countries' profiles that help you look at what's going on in your own particular country. The issue of access and security has really become heightened over the past few years. So trying to get a better sense of what are the geographical areas that could be affected. Do you have updated maps of areas where security and conflict could potentially interfere with what you're trying to do in an outbreak response? And what information do you have available to you in terms of an access plan and resources and support if needed? So I've said all that to say, really, we're trying to do several different things. We're trying to understand the context in 3 different areas. One, what do we know about the polio disease and vaccine? And so that we can inform the messages to be developed. What do we know about the health services in those particular areas that I talked about earlier? So we can inform the capacity need in terms of implementing the plans that we've been working on with our colleagues, epidemiology and health colleagues, and understanding really our local partners to the extent to see how can we really put together a crisis communication C4D team that involves UNICEF, but it involves the partners in a clear, cogent, coordinated fashion trying to respond to an outbreak. So we're trying to identify who these people are, what kind of services are in place, and what do we know about the evolution of the disease, what's happening with the disease. You've heard Ahmed already talk about the vaccine management. So what is all of that information that we have to pull together to really think now about our intervention from a behavior and a social change point of view? What are some of the data sources that are for relevant C4D? I know that UNICEF loves KAP surveys, but we're not really talking about that necessarily as something you have to have in order to think about prepositioning for a polio outbreak response. But we do think it is important that you look and are familiar with existing surveys and reports that you may have already in your offices, whether they be the mix or the demographic health survey data. Look at case investigation data that may be at facilities that your health colleagues has access to, the surveillance data. We think it's very important that C4D understand how to read, interpret surveillance data as well as the supplementary immunization activities data. Routine immunization data is available. Key informants, focus group discussions, all of those are important. We're not saying that you need to do all of them, but we're saying it is important for you to look at what kind of sources you have and your ability to analyze the data to look at how it can inform the C4D strategy that you're planning to employ. So think about it from the point of view, what types of rapid assessment tools do I need? Okay. What standard operational procedures should be in place for the research I may need or the rapid assessment? So do you have relationships already established with organizations within your country to help you collect some of this information? What kind of communication readiness do you need to have? In terms of, do you have an emergency training package on outbreak communication skills and needs that you could use to train volunteers that may be coming on board to work with you? Do you have a manual for volunteers on background information, messaging, and so forth? What monitoring mechanisms do you already have in place? Do you have the indicators identified up front? Those are the kinds of things you'd want to have in place, so should you have an outbreak, you're ready to move. You're not in the process of trying to develop all of this as it's happening to you. Last but not least, I want to focus a bit on materials and tools. And by this, we're really looking at the whole idea of a strategic stockpile for rapid response. So it's looking at what kind of communication materials for key messages can you already have in place that you can use. You're not trying to design new messaging immediately because you have some information already that you might be able to use. Can you look at that now, begin pulling out what might be useful for families, for local influencers, for health workers? We're not assuming you have to start from zero. So it's looking at what you have, what can you tweak, what can you adapt, should something happen, given your data that you've been collecting and analyzing. Can you prepare now? If a worst case scenario, if this happens, this is what we have available. What type of communication equipment do you have ready? Do you have portable radios? Can you use mobiles? Do you have to worry about and try to have access to megaphones? What is it that's available? It doesn't mean it's in the UNICEF office, but it means you have access to that. And you have done a mapping, if you will, to find out those type of resources that are available or not available. Lastly, the other thing to think about is when you think about this whole aspect in terms of materials and tools is to look at operational readiness. Again, I raised the point of long-term agreements. You might want to already have established that you can tap into within the office, access to desktop and graphic designers. So if you have to printing companies, so if you're having to do posters, flip charts, billboards, you already have that done. You're not waiting at the time of something happening to try to set those up. You have put those long-term agreements in place already in your office. You have with your office operations team already arrangements and contracts in place for transportation. Should it be needed for outreach, you've already thought that through, have a sense of the mechanism, how it would work. And key, because I think sometimes in UNICEF, the tendency is to think UNICEF has to do it all, is you would want to spend some time trying to see what's in the government stocks. Are there resources, materials, equipment there that you might have access to? But that means that you're thinking about it ahead of time to try to get a sense of what does it look like. So when you're looking at assessing, you're not looking at not only what you have, but you're looking at government, and you may even talk about looking at some of the stocks that some of your partners may have. I've talked about some of the key things on a practical sense around preparedness, and I remind you to go back to the matrix that Sahar shared with you earlier. When you've gone through thinking through some of the things I just talked about, you may want to go back to the matrix and re-look at how you would answer some of those questions, because the two go together. By answering the question, it helps you figure out where you may have gaps so you can focus. But what we've tried to do here is just to highlight some of the key areas you want to consider as you think about pre-positioning, trying to anticipate where support may be needed and where you might need to reinforce what you already have or need to complement in terms of your office. I'll stop here and we'll open it up for questions and experiences from other colleagues.
Thank you, Irma, so much for your clear summary of security preparedness and prepositioning. I see we have had a couple of comments come through while Irma was presenting, so I will read those out. As well, I invite people, the same as the vaccine management portion, to write their questions in the little side messenger at the bottom, and I'll read them and Irma can respond. So while you're gathering your thoughts, I just want to go to the next slide, and I'm going to leave this up here while we do questions and answers. But this is the global resources, which there are many of, for polio preparedness and response. So we have the overall technical polio materials and guiding tools, including the updated outbreak response SOPs as of May of this year, the polio outbreak C4D guidelines, which were referred to in this webinar, as well as cold chain logistics and MOPV2 guidelines. Also what Ahmet talked about, the polio communication global guide and the global frontline workers training kit. All of these are available online, which there's a few web-based platforms, the GPI website, and within that you want to go to the Tools, Protocols, and Guidelines tab. And as Ahmet mentioned, a lot of these get updated quite frequently, so it's important to check back and download the newest copies, as well as Rhizome, which is dedicated to C4D and polio outbreak response and preparedness and has a wealth of information, including a library. And of course, Agora, which has many different courses, including the CCL and VM online course, but also different ones, micro-planning for immunization, there's also communication for immunization, and that's a great way to build capacity in the form of preparedness. Ultimately, the second bullet there is the UNICEF Polio Preparedness Framework, and there I've put the Dropbox link for the actual template, as well as the cover note. And we strongly encourage you to look at that, and if you have questions or feedback, you can email us as well, but this would be a great way to identify the gaps in your preparedness in country. So if you have any questions, please share them now, and Irma is very happy to answer them. I'm just going to read out some of the comments that were made while you were presenting, Irma. From Martin, he said, the choice of rapid response strategy for Somalia is mostly dictated by the selected accessibility of various parts of the country. Here, not everyone can go everywhere. This is different from the Chad context, for example. Do you have any feedback on that?
Well, I think that's important to really, I think the point that you're making is a critical one, and it's really understanding the context of the country and what is feasible and what is possible to do. So I talked about the government capacity, but clearly what you're raising is an issue where security and safety is an issue in terms of one's ability to have access. And the key is not necessarily having to do model 1, 2, or 3, but really adapting to what seems to be the need for the country given the situation. I agree.
Another one from Sotarine said, for better appropriation and to fight against polio, we need to involve all practitioners and clinicians in social mobilization activities because many do not know exactly what we are doing. Activities are very often carried out exclusively by health district staff, and other clinicians are excluded when they can contribute.
I think that's an important piece of the prepositioning. And if you know that you have access to other professionals who can be of assistance, one would anticipate that you would do some of that capacity building, working with them ahead of time so they're familiar and they're comfortable working in a polio or immunization situation. So I think it is important to think there are other people that can help. The question is making sure that you have the training materials and the support helping them get ready to be able to work with you in this regard. Sahar?
And if I can add very quickly, I think for this one and the one before, what's important about the whole preparedness piece and the prepositioning, as Irma mentioned, is that it's not seen as something that UNICEF will do by itself. This is collective work that we will have to do with our partners, primarily the government, because they still own the whole program and they are the one responsible for. Our position is to help them deliver a quality campaign on time. But we will never be able to replace the government, not even in the most vulnerable countries or contexts. And to the point Martin mentioned, I think the idea is the point is very well taken, Martin, but what I would add to that is that the critical issue here is not about the scale of what you do and the data collection, it's more about being consistent, to have some sort of a measure, no matter how small or how primitive even if it could be, that would go before what you do, during and after, so that you always have snapshots at different points of time that could validate whatever you've done was really meaningful, bringing the lessons required to adjust if needed afterwards, and what was the outcome. So I think this is, at the end of the day, what matters. It's not about the scale or how big or how exhausting it needs to be. Over.
Also, Barima made the point, he was just in relation to something you said earlier on, that it's also important to have I think it's a sensitization of weekly markets where children go with their parents. So another way to capture.
Definitely. Definitely. But I think given that point that you're raising about the markets, it means one, that one has really got an understanding of when those markets are held, what kinds of things. Again, that's something one can do from prepositioning. It doesn't have to wait for an outbreak. If you know already that people take their children there may be other kinds of things that are going on that you can build on. So I think the other way to think about responding to a polio outbreak is when there's communications and C4D activities going on already, to build on those. It isn't just we're going to start something new.
To add to what Irma said also, colleagues, this is important because it does very much inform, in many situations, even the decisions our colleagues at WHO or the government would make. So you need to value highly the importance of this kind of social information, because this is not light. The point Burima is mentioning now could even determine times of the campaigns. In many countries, we've seen countries shifting to 6 in the morning, to 8 in the morning, or to 9 in the morning for different reasons. In many other situations, we had to start on a Sunday, or we had to start on a Friday to catch the parents wherever they are, so that we can minimize the chance of missing children. So don't shy away by bringing and pushing for some of those information to make some of the critical decisions around the response and how it would look like.
A few more comments here. First, just Martin responded, and this is a good example of preparedness. In Somalia, we have a MOPV2 campaign in about 2 weeks. The team took the measure to withdraw BOPV from all districts involved to avoid any mix-up.
Absolutely.
So this is a good example. A question from Kamal is, using testimony of families affected by polio, what should be the ethical red line to consider?
Ethical red line to consider in terms of, I'm not quite sure what you're asking me. Are you asking me, is it ethical to have that conversation with them, or is it ethical to share what they have, the information they have provided you? I think a couple of things. One, of course, you would want to have any kind, if you're talking to people, you want informed consent. You'd like to give them a sense of what you're going to do with this information. It isn't just you hear their testimonies. It's, would it be okay, or I plan to share this with this, that, and other. Where possible, you would probably want to share their information in a way that does not give up their identity.
He also specified it's about showing children with polio.
Showing pictures of children with polio, is it ethical to show children?
Kamal, if you want to extrapolate on that a little bit, and we'll come back to that comment.
If you could just clarify a bit further,
Yeah.
Is the issue, is it ethical to show children with polio? Is that the question?
Let's see, he's getting more feedback. From Hussein, and also Hussein mentions two really important pieces about data, that in addition to MIC, MICS, MICS,
Yes.
and DHS, we have to look for coverage evaluation survey for RI. As well as to evaluate coverage, we also need to do LQS during campaign and IM in the post-campaign.
Yes, those are.
Okay.
No, that wasn't a question, it was a fact.
A good fact. Okay, so Kamal has specified it's about showing children their faces with polio. So I think it's probably what you're mentioning about identity.
Yeah.
So from Barima, he says, also wanted to raise the fact that we need, in security compromised and hard to reach areas, to map the most trusted communication channels, local and national NGOs working in these areas for prepositioning.
Yes.
All very good facts. If anyone has
Facts.
questions, please share. And another good fact from Martin, in Somalia we agreed to present a sketch drawing of a paralyzed kid in IEC materials rather than actual children, so to protect their identities. I'm going to ask for just one or two more questions before we wrap up. Since we are over time, if you have them, please send them now. And if not, you can send them to me later, and we will find you the answers and share them back with you And just a reminder, this webinar is recorded, and we will have the recording posted on GPI website and also mailed out to those that were invited, which all of you were, and as well as the presentation for your reference. And if you have any questions on the Polio Preparedness Framework, please do not hesitate to email myself, Alex McFedrin, or Sahar Higazi, and we will support you in that way.
Let me just also add that in addition to the suggestion of using images rather than the actual child's face, is just to remind you that UNICEF has guidelines on what you can and cannot do in terms of the type of photography that you can use in work that you're undertaking. So I would suggest that you go back online and go to the internet and look at what those guidelines are. They're very, very specific about what you can and can't do. Clearly, one of the things you need to have is informed consent, but the extent to which you're going to show a child's face who's been paralyzed from polio, that takes you to a whole nother level. So please look at the guidelines that UNICEF has put together.
I think that's all we have for questions. I don't see any more. If you do have them, please email me directly and we will be happy to follow up. Thank you all for taking the time to join us. Oh, I have one question. It looks like a good one. Sutterine asked, what is the best option to present images on communication media? Okay, so we just answered that. Should children be shown paralyzed or not? This is what Irma just was discussing, that we should refer to the UNICEF guidelines available on the internet. They're very specific. And obviously protecting the identity is very important, and I think that's why Martin was suggesting they use sketches of children instead. And I think you'd see the same in the global communication guide for polio, that it's sketches as well, so it's cartoon images. Thank you guys very much, everyone, for joining. Have a great evening or morning, afternoon, and we look forward to having another webinar with you soon. Have a great day.
Bye.